Thank you for choosing Axxess On Demand. We're the fastest growing home health technology company, helping improve care for more than 1.5 million patients and trusted by more than 7,000 healthcare organizations to grow their business. Axxess is a firm believer in continuing training, and we create content so you can learn and grow anywhere, anytime. Let's get started.
Hello, this is Jennifer Gibson with Axxess. We are here today to talk about the updated conditions of participation. This is part 5 of a 7-part series, and today we're going to talk about QAPI as it relates to the updated home health conditions of participation. As we said before, I'm Jennifer Gibson, your RN trainer, and we're glad to have you with us today. Our objectives for this session are to learn the differences between current and updated regulation as it relates to QAPI. We want to become knowledgeable in the parts of the QAPI standards that are in the updated home health conditions of participation, and we're going to identify ways the agency can implement new conditions of participation related to QAPI. Then we'll understand your agency's responsibility in ensuring the QAPI standards are met. You'll find the regulation for QAPI in the new and updated home health conditions of participation. They're under Subpart B, which is all the patient care related pieces of the updated COPs, and you'll actually find it at 484.65, Quality Assessment and Performance Improvement QAPI. You'll see here at the preamble to 484.65, there's a pretty large amount of information about what QAPI means and what we're responsible for. But let's take this and go over it really quickly, and then we're going to dissect that and go into what all of this means. We see here that the agency must develop, implement, evaluate, and maintain an effective, ongoing, home health agency-wide, data-driven QAPI program. The home health agency's governing body must ensure that the program reflects the complexity of its organization and services, that it involves all home health agency services, including those services provided under contract or arrangement, that the QAPI program focuses on indicators related to improved outcomes, including the use of emergent care services, hospital admissions and readmissions, and takes actions that address the agency's performance across the spectrum of care, including the prevention and reduction of medical errors. The home health agency must maintain documentary evidence of its QAPI program and be able to demonstrate its operation to CMS. So let's think about what all that means, and we're going to dissect that sentence by sentence here. So let's look at the first part of that preamble. It says the home health agency must develop, implement, evaluate, and maintain an effective, ongoing, agency-wide, data-driven QAPI program. So first of all, let's think about what we're doing currently under the current COPs. Do you actually have an active QAPI program now? And most of us will say, yes, we do. We have to in order to become certified as a home health agency. What does that really look like now? Most of us, when we think about QAPI, we think about chart review and correcting notes and all of those things. And those are a part of QAPI. But what I want you to think about when you're looking at chart review, you're really doing that after the fact. By the time you get to chart review, that care's already happened. You're really just reviewing to make sure that policies and processes are being followed and that there's a skilled need and medical necessities proven, that homebound status is written, and all of those kinds of things. But when you're thinking about a true QAPI program, you're talking about data-driven. What's going on? How are we doing? Are patients going into the hospital? If so, why are they going in? Is this a wound deterioration? Is it an injury due to a fall? And then when you find out what those problems are, you go in and start looking at your data, and then you look at the charts that back up that data and see if you did everything that you could to keep that patient out of the hospital or the ER in this case. So think about your QAPI program that you have now. How do you evaluate that program? Who all is involved in evaluation and maintenance of that program? What disciplines are involved? And what data are you currently using? The current QAPI COPs changed from incident-based, after-the-fact focused to preemptive focus about 1999. And that's about the time we got the Oasis. And if you think about what the Oasis is for, the name Oasis itself is an acronym. It's an outcomes assessment data system, right? So when you think about the outcomes assessment, that Oasis is really used to analyze data, okay? That's why in some cases, the Oasis items are assessed a little bit differently than our professional head-to-toe assessment. There are things that we have to factor in on an Oasis item that's a little bit different than what we factor in from a head-to-toe assessment. For example, on the ADLs, we have to factor in whether or not the patient can do these things independently and safely. Whereas just a head-to-toe assessment, we are gathering information about the physiology of the body systems, for example. Now, the current QAPI rely on problem-oriented, external, after-the-fact occurrence approach to resolve patient issues. We look at incidents, we look at infections, kind of after the fact. We'll get an incident report or an infection control report, and then at that point, that's already happened, right? So we have to look at that and make sure that the medications cleared up the infection, for example, try to figure out how they got the infection, and so on. And that's still a little bit after the fact. So with your updated QAPI COPs, they require more of a proactive performance monitoring through an effective, ongoing, agency-wide, data-driven QAPI program under supervision of the governing body. And that's the other key piece. Under supervision of the governing body. That governing body is now going to be responsible for the QAPI and the performance and making sure that that QAPI program runs as it should. The new QAPI Conditions of Participation replace two existing COPs that we are under currently. Those are the Group of Professional Personnel and the Evaluation of the Agency's Program. Now, don't get confused about that replace part, because the guidance and the standards under Group of Professional Personnel and Evaluation of the Agency's Program, those don't go away. What happens is they're moved to a different section under a different title, which is our QAPI, and then we add several other standards as well. We see those added too. So it's an expanded COP really, but those two sections are completely gone as far as how they're titled. So when we talk about replacing those existing COPs, we are talking about replacing the title and the location and so on, but a lot of those standards are still there and they're enhanced, okay? So your updated COPs for QAPI in the end up being more consistent, and they are consistent with the requirements for end-stage renal disease programs, hospitals, hospices, your organ procurement organizations, and your transplant centers. Current COPs, what we're working under until the implementation of the updated COPs, are Group of Professional Personnel, that's located at 484.16, and that tells you that you must have at least one physician and one RN, preferably a public health nurse who's trained a little bit differently than just a regular RN. The public health nurse, usually you'll see that with some kind of a credential, although a home health nurse works very well in that position as well. It's preferable, not mandated, that they be a public health nurse. And then then your group of professional personnel must also have an appropriate representative from other professional disciplines. So for example, if your services include PT and OT, but not speech therapy, you would expect to have a physical therapist and an occupational therapist on your group of professional personnel, and then whatever other professional services you have. And then you have to have at least one member of the group that's neither an owner nor an employee. So that's going to be your consumer representative, so to speak. And that's your group of professional personnel. We often refer to this as our PAC committee as well. But this group of professional personnel, their job is to really oversee your policies and make sure that your company is running as it should and servicing clients properly. You'll see here the group establishes and annually reviews the agency's policies governing the scope of services offered, your admission and discharge policies, your medical supervision and plans of care, the emergency care, clinical records, personnel qualifications, and program evaluation. So when you think about who all is on this group of professional personnel or your PAC committee, you can see why it's important to have the professionals and a physician and an RN and then a community representative. Perhaps the community representative tells you that, there's just nobody in this county who really does good non-medical aid services. And you can tell them, well, that's not usually covered under Medicare and Medicaid, Medicaid only PAS type services, and maybe you decide as a group that maybe you need to become a PAS provider. Those are the kinds of things that are discussed in your PAC committee meetings and so on. Your professional advisory committee or PAC committee should meet frequently, as how this is stated in your current COPs. Frequently, most agencies do their PAC committee meetings at least twice a year. I recommend quarterly, but again, twice a year at the minimum. And what you need to do is your PAC committee is going to meet and advise the agency on professional issues. They participate in the evaluation of the agency's program. They assist the agency in maintaining liaison with other healthcare providers in the community. And then they help look at your care to see if that care is appropriate, adequate, effective, and efficient. And your business that you conduct in those meetings should be documented in minutes so that you can prove to your surveyor and to CMS that you're actually having these PAC committee meetings, your group of professional personnel, and what you talked about and what you went over, what was presented, what was discussed, so on and so forth. Now, in the updated COPs, you're going to see 5 new standards related to QAPI. Those 5 standards are the program scope, the program data, program activities, performance improvement projects, and executive responsibilities. So now that we've talked about and refreshed our memory as to the overseeing of the governing body and who the governing body is in current regulation, we see in the updated COPs at 484.65 that the agency's governing body is really taking on a lot more responsibility in the updated COP environment. It says here that the agency's governing body must ensure that the program, talking about QAPI program, reflects the complexity of the organization and services, that it involves all home health agency services, including services provided under contract or arrangement. So even if you have PT only under contract therapist, you still have to involve them in your QAPI program. We also see that the governing body has to ensure that the program focuses on indicators related to improved outcomes, including the use of emergent care services, hospital admissions and readmissions, and that the governing body ensures the program takes actions that address the agency's performance across the spectrum of care, including the prevention and reduction of medical errors. We also see that the agency must maintain documentary evidence of its QAPI program and be able to demonstrate its operation to CMS. Again, make sure you document in minute form your PAC committee's meetings and what you've talked about, how you addressed your hospital readmissions, how you addressed your emergency room visits and so on, what you talked about specifically, what you can improve on, what you're planning on doing. Are you updating your policies and processes? Are you including people that you didn't include before, and so on? Whatever it is that you're doing to help improve your quality of care, you want to make sure that's documented in minute form as you discuss that in your committee meetings. Now we're going to review the standards that we mentioned a little bit ago. At 484.65A, we see the first standard under our new QAPI program, and that covers program scope. What they're looking for a data-driven QAPI program that's capable of showing measurable improvement on indicators and evidence that the improvement led to better outcomes. For example, if you're looking at reduced hospitalizations and readmissions, they want you to be able to measure, analyze, and track quality indicators, your adverse events, for example. And how do you get that information and that data? That's going to come from your Oasis Casper Reports, as well as any other chart reviews and such that you do. But your adverse events, and we're going to look at this toward the end of our session today. We're going to look at some examples of Casper Reports and so on, and show you how you look at those, how you can monitor those, and so on. At Standard Program Scope A1, it says the program must at least be capable of showing measurable improvement in indicators for which there is evidence that improvement in those indicators will improve health outcomes, patient safety, and quality of care. At number 2, under the Standard Program Scope, the agency must measure, analyze, and track quality indicators, including adverse patient events and other aspects of performance that enable the agency to assess processes of care, agency services, and operations. So what does that mean when you're measuring, analyzing, tracking quality indicators, including your adverse patient events? So when you're looking at your adverse events and your Casper reports, and maybe you see that you sent more patients to the hospital due to injuries related to a fall than your state and national levels, clearly you would expect to see that mentioned in your QAPI program. In your Casper reports, when you get into adverse events especially, are going to tell you which patients flagged out in that respect. And so those are the charts that you would then go and look at to see that your policies were maintained. Was your frequency and duration adequate? Did you call and get orders as appropriate? Did you actually do a fall assessment? Do you have a standardized fall assessment that you're doing? Maybe you want to change that to a different kind. Are you working with contract therapists only? And is there clear communication between that therapist and the rest of the interdisciplinary team? All of those factors that might play a part in why these patients went to the hospital with an injury due to fall. Now, it's not to say that it's all your fault as an agency, of course. What you're looking for are what factors contributed to this injury and this fall, and what factors did you have control over versus those that you didn't. Maybe this person didn't have a caregiver who could be with them when you're not in the home. And so you might be looking at whether or not you got a social worker involved to help find community resources for this person. Are those things being documented and communicated with your physician who ordered the home health plan of care? And are they looking to see if there are other alternatives for this patient? Maybe that home is not the best place for the patient if they don't have a caregiver and the patient's unable to safely ambulate and they're not progressing well. All of those different things. And then you'll monitor that from quarter to quarter, maybe even monthly. If you have real-life data analytics possible for your agency besides the Casper reports, you could monitor that more often through your QAPI program and then present that quarterly to your committees. You might actually have a QAPI committee that meets more often than your PAC committee. A lot of agencies have a QAPI committee as well as a PAC committee, for example, and that QAPI committee goes over things on a monthly basis, performs chart reviews, analyzes data, and then they present that to their PAC committee quarterly. That's one suggestion of how you can do that. So really what we're looking at here is measuring, analyzing, and tracking those quality indicators. So like we talked about, when you look at those Casper reports, and you see that you've got a higher number than the state and the national averages, you're wanting to see if the changes that you've made are going to lower those numbers and get you more in line with being either equal to and hopefully even less than the incidence of state and national percentages, for example, on your adverse events, and see if that's actually helping your processes, or is that helping bring the numbers down. That's really what QAPI is all about, okay? Under 48465 standard program data, this is the second of the standards for QAPI. You see that you're going to use quality indicator data, including measures derived from the Oasis Casper reports where applicable, and other relevant data. And that data is going to be used to assess the quality of care provided to patients and identify or prioritize opportunities for improvement. Your examples would be high priority safety and health conditions. You see under Standard B, number 1, the program has to utilize quality indicator data, including measures derived from the Oasis where applicable, and other relevant data in the design of its program. So what else are you going to use besides your Oasis to assess and analyze and monitor the improvements that your agency's making in the quality of care given to your patients? You might look at not only your Casper reports, you would of course want to look at things like Home Health Compare, your CAPS quality standards, your responses on your CAPS surveys, your PEPR reports, for example. There's lots of different ways to gather information for QAPI besides just a standard review of the chart. The agency must use the data collected to monitor the effectiveness and safety of services and quality of care, and to identify opportunities for improvement. No matter how good we are, there are always opportunities for improvement. And you're really wanting to get better than your state and national averages, right? That way you can set yourself apart from your competitors. You can go and speak to your hospitals about their rehospitalizations and how you've improved your rehospitalization rate to maybe from 12, which is the national average, down to 6% rehospitalizations. And you have a really good group of respiratory nurses or cardiac nurses who that's their specialty, and you see that this hospital has a lot of rehospitalizations because of CHF and COPD, and now you can go in with your QAPI numbers and show we decreased hours through this program. We'd love to help you decrease your rehospitalizations by using the programs that we've implemented. Let's partner up. So not only does this help you with QAPI for CMS, but it can also be used in your marketing and liaison with your hospitals and different entities. And now, because if you're doing this data-driven quality improvement, you're able to take that data and show that off and brag about that to your competition and to your referral sources. The third point under Part B program data is that the frequency and detail of the data collection must be approved by the agency's governing body. So as you're thinking about the QAPI program that you want to put together, you're going to outline that out, what it looks like, how often you're going to monitor it, what data you're going to use, and so on. You'll present that to your governing body, and in your minutes, it should be shown that they approved this frequency and detail of the data collection that you plan to do. And then each time you meet back with the PAC committee, you'll present what you've collected, what you've deduced from that information and that data, and how you plan to change up for the next quarter, and so on. Under 48465 Standard C, we see the Program Activity Standard. The program activities require the agency to focus on high risk, high volume, or problem-prone areas of service. So you need to consider the incidence, the prevalence, and the severity of problems in those areas. The agency is expected to immediately correct any identified problems that directly or potentially threaten the health and safety of patients. And then you're going to track and analyze any of the events that you have and continue to monitor those even when improvement has occurred. What are we talking about there? Let's break that down a little bit. At Standard C number 1, the agency's performance improvement activities must focus on high risk, high volume, or problem-prone areas. What does that mean? High risk could be something, for example, that you might not do often at your agency. Perhaps you seldom take IV cases at your agency. That alone could make that a high-risk skill because you may not be most up-to-date with the different types of pumps or the equipment that's used in IVs, or you may not have the skill set that perhaps to the level that's needed for IVs at home. Maybe you've not ever delivered blood in the home and now you're going to try and take that on. What are you going to do? Those are high-risk areas. You're going to want to recommend and research, for example, maybe doing the IV Nurses Society's policies and adopt those as your own. You're going to want to train your nurses. Maybe you want to recruit a nurse who has really good high IV skills, and so on, and focus on that as a QAPI study because that is a high-risk area for you. When we're talking about high volume, we're talking more along the lines of something that you just do an awful lot of. Maybe you do tons of vacuum-assisted closure or wound vacs or negative pressure wound therapy. It's called many different things. You do a lot of those cases. And just because of the sheer volume of the cases that you get, you're at risk for problems with infection or problems because of the just sheer volume of the number of patients you have. And then your problem-prone areas, perhaps in chart review you see that you have a lot of stage 3 and 4 wounds, but you never see documented any tunneling or undermining. That can be a problem-prone area because we know the WOCN guidance tells us that stage 3 pressure wounds will sometimes have tunneling and undermining, and that most stage 4s have some tunneling or undermining. So from that alone, you're aware that this could be a problem for you because it's not documented. So maybe we want to do a wound assessment and do a skills checklist on how to assess for tunneling and undermining and monitor those patients and see how they do. Do they end up with wound infections, but you never see tunneling and undermining mentioned in the charts? That could be a problem for you. Those are some examples I can think of about your QAPI activities that focus on high risk, high volume, and problem-prone areas. You want to consider the incidence, the prevalence, and the severity of the problems that are in those areas. And if you notice a problem, you're going to immediately correct that. So let's say you review charts, you notice that this particular nurse that has this patient with the stage 4 pressure wound on a wound vac never mentions tunneling and undermining. So you go out and do an on-site with that nurse and realize that she doesn't know how to assess that properly. You wouldn't just leave and let her continue on with the same practice. You would want to make sure that you immediately correct that action. You're going to have some documented training. You're going to maybe look into hiring a WOCN. You might, in your committee meetings, decide that, you know what, as many wound care patients as we have, and we noted that there's some problems with knowledge status as far as how to assess, let's go ahead and consider and present to the PAC committee meeting through our data that we are really at a point where we need to hire a wound ostomy continence nurse to have on board to help us with these patients and mentor us. Those are some examples of QAPI programs and how you really consider the incidence, the prevalence, the high risk, the severity, and then immediately correct any identified problems that directly or potentially threaten the health and safety of patients. Under your program activities C2, performance improvement activities must track adverse patient events, analyze their causes, and implement preventative actions. This is where we're talking about with your Oasis Casper reports. You can go in and pull reports on your adverse patient events, analyze the charts for those particular patients, and see what caused the adverse event, and then what can you do to implement preventative actions to prevent this from happening in the future and getting those numbers down. Under Standard C3, you see the agency must take actions aimed at performance improvement, and after implementing those actions, the agency must measure its success and track performance to ensure that improvements are sustained. So you're looking at first quarter, we've got a problem. This quarter, we're going to monitor and analyze, and we're going to change our process and policy. We're going to do proficiency evaluations on how to measure Stage 3 and Stage 4 pressure wounds for undermining and tunneling. We're going to make sure all the nurses do that as a check off. And then next quarter, we're going to see if that helped. And then if next quarter your data comes out and lo and behold, it got better. You don't just stop monitoring at that point. You continue to monitor to see if this is a one-time thing or if this continues to be an improvement that's sustained. So just bear that in mind, that you are not only looking at improvements temporarily, but those improvements are sustained long-term. Under Standard D at 484.65, this is your performance improvement projects. Now, this is one part of the QAPI piece that's a little bit delayed with the implementation of COPs. At the time of this recording, we have currently a proposed rule to postpone the implementation of the Home Health Conditions of Participation from July the 13th of 2017 to postpone that until January the 13th of 2018. That has not passed as of yet. It's still in a proposed rule status. It's not a final rule yet. So we don't yet know when the implementation of the home health COPs will go into effect. But as it stands today, they are slated to begin July the 13th, except for this particular piece under QAPI, which is a performance improvement project. Currently, as stated, the COPs related to performance improvement projects are to begin January 13th, 2018. So you have a little bit of time to really think about your performance improvement projects and gather data and so on. Now, should the proposed rule to delay the COPs go into effect, the final rule will be published and we'll know that it's all been pushed back by 6 months. If that happens, the QAPI piece will be spoken to most likely as well, And this will be told, I would imagine, we'll have to see what the final rule says, this will be rolled back from January 13th, 2018 till possibly July the 13th of 2018 instead of January. So just keep an eye out for, of course, we'll make sure we put blog articles up when this happens, if and when it happens, and we'll also do some education. But just know, as it stands right now, even though we're hearing rumors about a delay of the COPs, they could possibly be implemented right on the timetable that we already have, which is July 13th, 2017. And for this particular performance improvement project, that could very well begin January 13th, 2018. Anyway, those performance improvement projects should reflect the scope, complexity, and past performance of your agency services. They should be conducted at least annually and focus on areas of past performance that have been problematic. For example, wound care might be high risk if your agency doesn't perform it often or they're not up to date on the latest techniques. Another example would be wound care, which could also be high volume for another agency with a large number of patients who require wound care services. So if you have a large number of patients, obviously you're looking at increasing the likelihood of problems due to the sheer volume of the wound care visits that would occur. At 484.65D, we see the standard for the performance improvement projects. And again, as it is right now, until we get a final rule saying that they have definitely been postponed, the performance improvement projects are slated to begin January the 13th of 2018, and agencies have to conduct performance improvement projects beginning on that date. The number and scope of distinct improvement projects conducted annually must reflect the scope, complexity, and past performance of your agency services and operations. I usually say quarterly, don't choose more than 2 or 3 different projects to work on. And so if you're using those same 2 or 3 each quarter till they're nailed down, you may have 6 or 8 or even 12 if you do a new one each quarter. You may have several projects to look at annually. Okay, just bear that in mind. You want the annual review to be comprehensive of all the different projects you've worked on each year. You also see here at D2, the agency must document the quality improvement projects undertaken, the reason for conducting those projects, and then the measurable progress achieved on those projects. At 484.65E, we see the standard for executive responsibilities. And as we mentioned earlier in the webinar, the agency's governing body is responsible for ensuring, and that tells you right there, the governing body assumes responsibility for the QAPI program. If it's not running well, who are they going to look at? Your governing body. Yes, the administrator will also have a part, and your DON and so on, responsibility for that. But as far as who is CMS looking at, the governing body assumes responsibility. So make sure you keep that in mind. Make sure that the persons that are on your PAC committee understand with the new COPs. They're going to have to really do some work with helping you on your QAPI and making sure that they know their responsibilities as well. They need to ensure that the QAPI program reflects the complexity of the agency and its services, that it involves all the services provided, it's focused on improved outcomes, and that the governing body ensures the agency took actions to prevent and reduce medical errors. By the way, when we're talking about medical errors, don't think of that as only errors that your agency might have inadvertently caused. Think also of monitoring for medication errors, such as patient being discharged home with duplicate medications, or you get out to the patient's home on admission and realize they're taking furosemide and Lasix because they didn't realize it's the same drug. That's also a medical error, and it should be monitored even though that was out of your control. What that might show is that you could perhaps improve communication between yourself and the referring parties to improve reduction of medical errors in that way. That maybe they need to look at, you might find out, for example, that that particular company referred you X number of patients, and 2 out of that number of patients came home taking duplicate medicines. You're letting them know you're going to work with them to liaison, have them double check the patient's medication list and compare that to what they had when they came into the office and so on. Those are things that you're talking about doing to prevent and reduce medical errors that may not even be your agency's problems as far as your agency committing the errors, but that your agency picked up on them and you communicated that back to your liaisons. That's always a good idea. At E1, we see that the governing body is responsible for ensuring the following. Number one, that the ongoing program for quality improvement and patient safety is defined, implemented, and maintained. At E2, we see that the governing body is responsible for ensuring that the agency-wide quality assessment and performance improvement efforts address priorities for improved quality of care and patient safety, and that all improvement actions are evaluated for effectiveness. At E3, we see the governing body is responsible for ensuring that the clear expectations for patient safety are established, implemented, and maintained. And at 4, that any findings of fraud or waste are appropriately addressed. Okay, so the executive responsibilities, your PAC committee, your governing body is responsible for ensuring that findings of fraud or waste are appropriately addressed as well. So that's a huge responsibility on that PAC committee. And that's one of the reasons that I advocate for more often than twice a year meetings. Quarterly helps to endorse the importance of what this committee's doing. It also gives you an opportunity to really monitor this closer to real time and see what's going on and stay on top of things so that you can ensure that these responsibilities are met. All right, so let's get into some QAPI real world and what we need to talk about here. There are currently 4 CMS Quality Initiative manuals. You have your Oasis C2 Guidance Manual, which was updated in 2016. Then you have your Outcome-Based Quality Improvement Manual, or OBQI. You have an Outcome-Based Quality Monitoring Manual, OBQM, and your Process-Based Quality Improvement, PBQI Manual. Those 3 manuals were mostly updated in 2012, one of which I think the last version was 2010 actually, and I didn't note it here on the slide, but one of those manuals last update was 2010. I would not be surprised to see those manuals being updated in the next few years. I don't know how quickly that might happen. We certainly see our Oasis being updated more frequently because of the Impact Act, and I think that will continue going forward, so we may actually have a newer Oasis set and guidance manual than 2016. We may get another in 2017 or 2018. I'm not sure. The point to all that, just to say this, make sure that you're looking at CMS's website and getting the latest copy of these manuals going forward. They can be found at the website that you see here. There's an actual whole page for QAPI program, and then there's sections where you can download these different manuals. Let's talk for a moment about process-based quality improvement. PBQI is the rate of use of certain evidence-based processes of care. Again, your Oasis C2 process measure items that focus on high risk, high volume, and problem-prone areas for home health in general goes under this process-based quality improvement section. And then your agency is going to add an additional layer by identifying your high risk, high volume, and problem-prone areas for the populations that you serve. Some examples from the Oasis C2 items for PBQI, you're looking at things such as timely initiation of care, drug education on all medications to the patient and caregiver during a short-term episode of care. You're looking at whether or not the patients had their influenza vaccines for current flu season. Have they ever had a pneumococcal vaccine? And then your pressure ulcer prevention. Those are some examples of processes. For example, under timely initiation of care, I still find many agencies having issues with timely initiation of care. Some of it is as simple as documentation errors. And what I mean by that is sometimes we still have agencies who don't realize that your referral date is the date that you last received orders before initiation of care. And I'll give you an example. Let's say on Thursday, you receive a referral that the patient's going to be coming home and will need home health care started on Saturday morning. And then on Friday afternoon, you get a phone call that we're not real sure they're going to come out, but we'll let you know. Lo and behold, the patient does not come out over the weekend, and so you get a call on Sunday or even Monday morning that the patient's going home today and they'll need to be admitted first thing Tuesday morning for IV care. Your referral date, and they send you over some orders for the IV care and so on. Your referral date's no longer Thursday of last week. Your referral date is now Monday of this week. And so if you don't amend your referral date, it looks like you don't have a proper timely initiation of care. Because if you use Thursday's date as the referral date and then Tuesday morning is your initiation of care, on paper, that looks like you didn't meet the 48-hour rule. But again, under the M items in the Oasis C2 guidance manual and the Q&As for the Oasis, it tells you that the actual referral date is the date that you last received orders before initiation of care. So if we document that on Monday when we updated our referral and got IV, and then we go out and admit the patient Tuesday morning, we certainly did meet that 48-hour rule. So those are some process-based QAPI things to think about. That's just an example of the things that we have on the list here. Your reports for process-based quality improvement, or PBQI, are found in your Oasis Casper reporting system. Now, you'll need to find out who it is at your agency, if it's not you listening, has access to your Casper reports and can pull these down for you. And then you'll need to define how often you want to look at those Casper reports, because you get to define the reporting period that you're looking at. Are you going to look at this quarterly? So you want to go back and pull, say, from January until March? Are you going to do it yearly? So you're going to look at January to January? Or are you going to do it monthly? Because maybe you really want to focus in on what's going on. You can define that. Are you looking at quarterly, yearly, or monthly reports here? What I have here is a sample Casper report from the PBQI manual. This is not at a complete page. You see there's 4 pages for this figure 2, but there are some things I wanted to point out to you, and if you'll look with me, we'll point this out. Starting in the left-hand corner, you'll see agency name and agency ID and the location. You'll also see CCN and the branch, the Medicaid number, the date the report was printed. That's important to know. And then in the upper right-hand corner, you see requested current period, 1/2011 to 12/2011. Again, you get to define that period. The requested prior period, and it tells you what period they're looking at to compare the data. It's going to look at the same period of time last year, so 1/2010 to 12/2010. Your actual current period is January 2011 to December 2011, and then your actual prior period is January 2010 to 12/2010. The number of cases, currently 701, prior 601. What does that mean? In the time period that we pulled, the current period, 1/2011 to 12/2011, we have 701 cases in that period. And for the prior period, January through December 2010, we had 601 cases. What does that mean? That means you have the number of quality episodes in that period of time. So currently we have 701 quality episodes. Prior we had 601 episodes. Now remember, your quality episode is different than your payment episode. Payment episodes are those 60-day periods that we often think about when we talk about episodes. But a quality episode starts when care is initiated and it ends when care is stopped. So for example, in a 60-day period, your pay period, you may have a patient who's admitted, transferred, then you have a resumption of care and a recert, and then the next 60-day period you have a transfer, a resumption of care, and a discharge. So in your quality episodes, you're not thinking about the 60-day periods. You're thinking about episodes of quality. You're looking at, in that case, the day the patient was admitted all the way to the transfer. That's one quality episode. And then your next quality episode begins at the resumption of care and ends at discharge. So your quality episodes are a little different than those 60-day periods. Your number of cases in reference sample, in the upper right-hand corner, the last thing on that list, number of cases in reference sample, 3569067. That number tells you the total number of cases nationwide for Medicare, Medicaid home health agencies the total number of quality episodes for the time period that you defined. Okay, so now that you have some background, let's look at this little graph here. And this one is in particular the Process Quality Measure Report. We're looking at timely care, the timely initiation of care item. You'll see the first column, or the first part of this linear graph, 701, that's the number of cases. That puts you at 77% of your patients had timely initiation of care. The 652, 66%, that's your prior sample. Okay, so last year, the January 2010 to 12/2010, you had 66% timely initiation of care, and then your national average, or the reference sample, is 73%. So what are we looking at in this particular graph from this Casper report? We see that we're doing better than our last year's sample and better than the national average on timely initiation of care. Okay, so that's kind of how you're interpreting this particular report. And it goes through all kinds of different process measures in this particular Casper report that you're going to identify the same. Now, something you'd want to focus on would be if you came here and you looked at timely initiation of care, and let's say that your last year was 66%, the national average is 73%, and yours is 62%. Then we have a problem because we're not doing as well as we were last year, and we're not doing as well as the national average. What am I going to do? I'm going to go back and review my admissions and see if we're getting that referral date proper. Are we documenting that properly? Do we really know how to document the referral date? And are we then documenting reasons why we can't get out there within 48 hours? Maybe the patient refused and would not let you get out there within 48 hours. They said, nope, it's a holiday. I don't want you to come until the third day instead of the second day. If that's documented, you're still okay, but you want explainable reasons, and the explainable reasons cannot be out of the convenience or staffing problems for your agency. Okay, those don't cut it with CMS. The other part of PBQI that you want to think about are the primary reasons for measuring care processes. So we've talked about how you gather the information, what you're looking at, for example. Now, why are we monitoring those care processes? Number one, we want to evaluate the elements of care that are under the agency's control. We have control over when we initiate care for the patient, unless they completely say, no, you can't come on that day. And certainly in those cases, you would want to see where that's communicated to the physician, that you've explained to the patient why the doctor wanted you to come on that day, and then document that they understood all that, but they still said, nope, my family's here for the holidays. I don't want you to come until tomorrow. Document all that. You also want to promote the use of evidence-based care. You might hear those called best practices or BPIPs in our industry. Then you want to evaluate the impact of use of best practices on patient outcomes. Then you're going to notice that you have public reporting to assist consumers in home health agency comparisons. That's your home health compare. PBQI also helps with quality or value-based purchasing systems, and we certainly know quality or value-based purchasing systems, which we certainly know is a focus for CMS because we have home health value-based purchasing models going on nationwide in some states. And then last, to promote improvements in patient care across settings. So from the acute care hospital to a SNF to home health agency, or acute care straight into home health agency, we want to see improvements in care across those settings. And we see that being implemented through the Impact Act and other different measures currently. So you can see even with our updated QAPI standards that we're really looking at the bigger picture of improving quality and best practices across all the spectrum for Medicare and Medicaid recipients here. The next part of your QAPI program is OBQI, that's outcome-based quality improvement. This helps to aid your agency in assessing the quality of care delivered. It allows the opportunity to see how process changes impact patient outcomes. Because of patient demographic differences, these are more home health agency specific. Some examples of this would be improvement in ambulation. That's an outcome. And what you do in that case, you literally are comparing the patient's performance at start of care to the patient's performance at end of care. And again, we're talking about quality episodes here. So if you have an admission, and then you have a transfer, and then you have a resumption of care, and then you have a discharge, your improvement in ambulation outcomes would be measured from start of care to transfer, and then again from resumption of care until discharge. Don't think of it so much as start of care to discharge, because it's not always the case. You might also look at examples of whether or not your quality of care is impacted by the number of RNs who have BSN degrees, or if the patients are being screened for depression, for example. Those are things that are outcome-based QAPI examples. For your OB-QI, there's a little diagram here that I want to show you. This also came out of the OB-QI manual. You'll see this is an ongoing process with OB-QI. You first see at the very top in the middle, collection and transmission of patient outcome data. Part of the COPs are that we will actually transmit our Oasis data to the state through the QEIS or QIES system. That transmission of patient outcome data is then what is used to produce your risk-adjusted outcome report and the outcome analysis. That's your Casper report, and then you interpret those outcome reports, select which outcome you want to investigate. You do your process of care investigation. You see your outcome enhancement through the summary of findings, developing an action plan, then implementing and monitoring that action plan, and then you go and collect transmission of that data again, and you analyze it on an ongoing basis to see if those outcomes are getting better, and once they get better, are they maintained at that level. Outcomes-based quality monitoring examples are your potentially avoidable events and your agency patient-related characteristics. What does that mean? You're looking at, for example, one of the reports in your Casper is your agency patient-related characteristics. If, let's say, the national average for patients who receive Medicare and Medicaid home health services, that national average age is 72 years of age. If you look at your agency's characteristics, which are different depending on where you are, if your patient-related age is 82, for example, that's already a reason in and of itself that might factor into why your outcomes are not as good as national or state averages. Your patients are older. So those are some things that you're going to be looking at with your outcomes-based quality monitoring and your reports. Let's take a little look at an OB-QM Casper report here. You see your sample agency-related characteristics report. Again, looking on the left-hand side of this little snapshot, you'll see that you've got your agency's name, agency's ID, the location, the CCN, the branch, the Medicaid number, when you printed this report. The right-hand side, again, is telling you the requested period, the requested prior period, your actual period you're looking at, and the actual prior. You see the number of cases currently. In the January 2011 to 12/2011 sample, you had 601. And then January to December 2010 was your prior. You had 551 quality episodes in that reference point. The number of cases in the reference sample, again, that's the total number of quality episodes for all Medicare and Medicaid agencies nationally, and then that's how they calculate the percentages. Now, if you look over here on the left-hand side column under patient history, you have a current mean, prior mean, and reference mean. You'll see the age, 70.75, that's your current average patient age. Last year, which is the period that we looked at for this particular report, it was 70.96, and nationally it's 72.78. So by looking at this data, your patients are younger than the national average age for Medicare and Medicaid recipients. The next column tells you how many female patients you have as compared to how many you had last year and nationally. Then you see the races, the payment source, Medicare, Medicaid, Medicare HMO, so on and so forth, your episode timing. And then over on the right-hand side, you're looking at living arrangement assistance. For example, you have 33% currently who live alone. Last year, you had 32% who live alone. and your average nationally is 32.4. So you have more people living alone than the last year and national average. You also see lives with others, you're about the same as the reference mean, but more than last year. And then when you get into availability of assistance, let's look at, say, around-the-clock help, 39% for you. Prior, you had 40%. The average reference mean is 38%. So you have more patients who have help around the clock than the national level. You use this criteria then to look at your other things such as care management, ADLs, no assistance needed with ADLs. You have 63% who say they need no assistance or assessed to need no assistance with ADLs. The national average is 71.9%. So you have a lot less people who are graded as not needing assistance with ADLs than the national level. So again, you might look at that and interpret that, oh, that might help explain why we have some patients whose ADLs are not getting better. Or, wow, we have more patients who actually need help with ADLs than the national average. And that's going to skew your data a little bit. Again, this is just a little bit of a snapshot as far as what's going on. This is how you use your agency's patient-related characteristics to factor in data on your outcomes and processes as well. Let's look at this one in particular from your OB/QM report. And this is a close-up from the Casper report because this one really illustrates some things that you have control over and the risk. So again, under the general health status, the first column here is your current data sample. The middle column is the prior data sample, and the third column is the national average column, okay? So you have hospitalization risks. You have 7.2% of patients who had a recent decline in mental, emotional, and behavioral problems. Last year you had 7.0%, and the national average is 6.4%. So you can already tell you have more patients who have mental issues and declines than the national average and more than you had last year. Let's look at the history of falls. You have 62.9% this year. You had 58.7% last year, and the national average is 56.8%. You have quite a bit more patients with a history of falls than did the national average. When you're looking at that and you combine it with the patient's age, and it wasn't the truth in this particular case we just looked at, but let's say your average patient age were higher than the national average and they needed more assistance than the national average, that might be playing a part into why you have more patients with a history of falls as well, and then that might play into why you have more patients going back to the hospital with falls and injuries. You see what I'm talking about with this data analysis? You can look at your data and see if you can figure out what's going on with your patients. And when you combine this information with your chart reviews, then you begin to see where you can do patient care and implement some best practices or change up your agency's processes. For example, if you notice that you have more patients with a history of falls, you might actually want to look at using less contract therapy and hiring a couple of physical therapists who are full-time. You see what I'm talking about as far as implementing processes and making changes. That's just something to look at. And with your data, you can then go into your governing body and prove that you need these particular different disciplines, and you might need these changes, for example. All right, so what should you do now? We've talked a little bit about the new standards as compared to the current standards, some different parts of the QAPI program. What you really should be working on right now is evaluating your current QAPI program. Is it really working on data, or is it working on chart review only? You'll want to ensure your meeting minutes are up to date and current going forward if they're not already. You'll want to make sure you appoint or reappoint members of the governing body. Maybe you want to do your governing body meetings more often than twice a year. You think it's a good idea to go ahead and do it quarterly. You contact your physician and the physician says, ooh, I can't do more than twice a year. You might want to look at changing the physician who's on your governing body or adding the physicians that are on your governing body, etc. Make sure that your staff members who are doing QAPI performance reviews have access to the Casper reports and your CAPS reports. The CAPS reports, again, is the patient's reply on how the clinicians are doing. So if you're having low performance on, for example, teaching about all the different medications and high-risk medications, and then you look at your Casper data and you notice that the patients are responding that the nurse did not ask to see all the medications that are in the home, you already have identified a problem that you need to work on, and that's educating the nurses about how to do a proper medication reconciliation, okay? So those are just some ideas. Look at your agency's high risk, high volume, and poor performance areas, and then start planning your QAPI projects. Even though they are 6 months down the road, you can already start looking at some things and doing some projects and kind of getting the feel for how those are to be done before that's actually implemented 6 months after the implementation of the updated home health COPs. If you have questions, I'm happy to answer those. This is not a live session, however, so if you do have questions, please reach out to me on the following email address. That's jgibson@axxess.com. You can also give me a call or send me a text on the business number that you see here, my cellular number, 972-975-0417. Just bear in mind that I do teach a lot and travel quite a bit all over the U.S., so if I don't answer that phone, please go ahead and leave a message and I'll get back to you just as soon as possible. But those are the best ways to reach me, and that's by emailing or calling. If you do happen to call the Axxess office, you can certainly ask the representative to reach me if it's at all possible. But again, that may still take a few days. So the best way and the quickest way to reach me would be through email or through my cellular phone. Okay? We again thank you for attending the Axxess Conditions of Participation webinar series. I certainly hope you learned something today that you can put to use. Come back to us as we finish up the last two sessions, Part 6 and Part 7, which will focus on the infection control program and your emergency preparedness program as they relate to the COPs. Once again, thank you for choosing Axxess for your educational needs, and we hope to see you again real soon. Thank you.
Thank you for joining our on-demand training today and for choosing Axxess, a provider of innovative, cloud-based software, services, and solutions to help home health organizations improve patient care and grow their business. Axxess is the only healthcare technology company approved to award continuing education credits by the American Nurses Credentialing Center and is also the most recommended home health software on Software Advice. You can watch more on-demand training videos through our software or at axxess.com, where you can also find tutorials, blogs, white papers, and answers to frequently asked questions. Thanks again for choosing Axxess.